A very warm welcome to Professor Sofocleous, to Nicosia, to the University of Nicosia and the medical school. First and foremost, I'd like to say thank you to Stavros, a friend and colleague, who actually called me to say that he thought it would have been a good idea to co-host Professor Sofocleous together with the Cyprus Institute at the medical school, and to take advantage of your presence, Professor Sofocleous, to give a very interesting scientific presentation. And I really don't want to say very much here other than to say that it's a great pleasure to have somebody, a very distinguished clinical academic, Cypriot clinician and Cypriot academic who has excelled in the United States, in New York, in Weill Cornell Medical College, with an outstanding record in terms of publications, securing funds for major trials, and pioneering as a professor of interventional radiology, pioneering interventional oncology, particularly the field of targeted therapies of liver metastases. Very important topic in so many colorectal cancer, a very common malignancy with many patients affected with liver metastases, and some of them, of course, are not. It's not appropriate that they have surgical resection. So these are the therapies that Professor Sofocleous would like to present to us. So I don't want to say anything more. I'd like to invite Professor Sofocleous to present.
Thank you very much.
Thank you.
Well, thank you very much for the nice introduction, and thank you very much for the invitation. Yeah, go ahead. So first of all, Stavro, thank you very much for organizing this with the Cyprus Institute and the University of Nicosia. We met with Stavros in actually New York, and I was in a rush because I had to go to a fundraising for a company that actually has a product that is supposed to generate immune response when injected into an ablation zone. And I didn't have a chance to get to know him well. So then I said, this was a very interesting presentation he made about the activities of the Cyprus Institute. And I haven't been in touch with anything academic in Cyprus since I left back in 1985. And I said, maybe it's time to start this discussion. And here we are. So as you heard, all my career has been dedicated to interventional oncology. And as a matter of fact, to interventional oncology specifically for colorectal liver metastases. For those of you who don't know what interventional is, I like to describe that as an abstract surgery. Interventional radiology is a subspecialty. It used to be a subspecialty of radiology. In the United States, it has been now 9 years that is a National Board of Medical Examiners single specialty, so it's no longer a subspecialty. Unlike radiology, that is a laboratory specialty, interventional radiology is a clinical specialty, not unlike interventional cardiology, which also jumped, if we all remember, from radiology, with the first balloons being done in a fluoroscopy table where you do barium enemas. So there is a common origin of all these image-guided specialties, and we're going to see a little bit at the end where I think they will go. But for this presentation, we're going to talk specifically about interventional oncology for colorectal liver mets and how technology helped us improve our clinical practices through the years. I do have disclosures to tell you because I have received funds for research from the NIH, from the Society of Interventional Oncology, from the Society of Interventional Radiology Foundation. Also, I have received a lot of funding from industry, specifically J&J and Ethicon, which is a company that makes ablation devices and 3D platforms that evaluate the treatment effects of ablation. Similarly, I have received funding from Sirtex, Boston Scientific, and Varian. They're all companies that either manufacture devices that we use in interventional oncology or platforms of treatment assessments, which is what I do. And I have served as a consultant or in the advisory board of similar technological companies. Again, J&J, Immunophotonics, Turmo, and variant within the last 3 years. But we're going to talk about treatment of colorectal liver mets, and I'm sure, I don't know if we have any oncologists in the audience or on the web, or when anyone listens to this, will probably the first question is, why are we treating metastatic disease with local therapies? You know, the standard of care for metastatic disease is chemotherapy. So what is the role of any local treatment? And I like to show this paper that came from my hepatobiliary surgical group at Memorial Sloan Kettering, where they evaluated, as you can see here, over 1,200 patients. And they tried to see how many of these patients can be cured. And by cure, mean cancer is gone, there is nowhere in the body any cancer cell to be detected. And they found out on the 1,200 that they were resectable and they resected them, they had a cure of about 20.6%. And cure means they were alive over 10 years after the surgery, at which point there was no cancer detected. And of note, there are some factors that were associated with the ability to reach cure. One of those, of course, is the presentation. What's the volume of disease you start with, as expressed by biomarkers, such as the CA, the carcinoembryonic antigen, or the number of tumors, or the volume of the liver replaced by tumors. But also there was a very technical factor related with the overall survival on this population, and that was the ability of surgery to remove the cancer from the liver with a clear pathologic margin. And that is a technical endpoint that determines complete resection, or R0. Subsequently, we had some evidence that actually adding a local therapy, and specifically radiofrequency ablation plus minus resection, to standard of care oxaliplatin-based chemotherapy on non-resectable patients, actually, as you can see here, prolonged survival dramatically, 36% versus 9% for those that they were treated with standard of care chemotherapy alone. So there is a strong evidence that treating the liver metastases actually can prolong survival. And the reason is most patients think that you have to make them cancer zero. There's no cancer detected in the body. That's not true. The real reason that why we can achieve longer survival is because we push away or delay liver failure. So as long as we can treat without pushing them to liver failure, we spare the liver by being conquered by the cancer, and therefore they live longer without going to liver failure, which is the most common reason of death in this population, in metastatic colorectal cancer. Now, I'm going to remind you that the first robotic surgery in a patient with colorectal liver mets by the name of Prometheus was performed by Zeus. And he had this robotic device that was doing non-anatomic resections every day. And then he was taking out the metastases only to see that actually the liver regenerates. And as a matter of fact, this is the first PubMed evidence that you can resect the liver and it will regenerate without putting them in liver failure. Since then, we have done a little bit of progress. I don't know how much, because our robotic devices are not that great as Zeus bird. And we have yet to find the ideal treatment that will eradicate disease with no morbidity, no mortality, very minimal cost, and very minimal downtime in the hospital. So let's go now to interventional oncology as a local cure. How can we use non-surgical image-guided treatments to achieve similar results to surgery? Let's start with that. So first of all, for those of you who understand computer tomography, this is a tumor here that involves most of the right lobe, and it's a colorectal metastasis that is very different than this tumor that is much smaller and well-defined, or even this tumor that is even smaller than this one and more peripheral. And for a tumor like this, actually we don't have a local cure in IO. We may have some technologies to help resection, for example, portal vein embolization, or a form of internal radiation where we can give radioactive particles in that area of the liver to facilitate resection by allowing control of disease while the rest of the liver hypertrophies, similarly to the beak of the bird that Zeus was sending to Prometheus. But when you have a small tumor such as this, and in general under 3 centimeters, under 3 tumors in general, then you can start considering local therapies instead of surgery. And the first technology that developed to do that was called radiofrequency electrocautery, later known radiofrequency ablation. This is Tito Livraghi, one of the pioneers from Italy, as a matter of fact, Milan. And in the 90s, he was doing, if you can see here, one needle, no anesthesia, only ultrasound, and effectively killing tumor with the deposition of heat. When I went to Memorial about 20 years ago or so, actually more than 20 right now, our surgeons would only send us patients to do ablation that could not be resected. And then they had a surgical fellow that came to us and said, so well, let me compare surgery to ablation. And sure enough, as you can see, survival and local tumor control was much better for surgery than it was for ablation. Now, mind you, that ablation was done in 50% of patients that had already failed surgery. So clearly not comparable patients. And of course, they had comorbidities that they didn't allow them to go to surgery. Not to mention that we had no idea what does it mean to have a complete treatment with margins. Back then, I was really very, proud of interventional radiology. And when I saw these results, I said, that's unacceptable. We can't be doing this. So I went and reviewed all of our data, and I found some striking findings with regards to the margin. And the radiographic margin is not the same as a pathologic margin, but it's a surrogate image finding that can bring you maybe as close as possible to what a pathologic margin would be. And what we found was that if the margin was under 5 millimeters, 84% of the patients, of the tumors, would have a recurrence. And if it was 0, we would have actually a higher 100% recurrence on the area that we hadn't treated the tumor. So it was a very strong correlation that where you had suboptimal treatment, you will get a recurrence, and it will be geographically located very near where that suboptimal treatment was. And it was actually embarrassing because in 76% of what we at Memorial 15 years ago thought we were treating adequately, we had a suboptimal margin. And nobody knew about it because we were not assessing for the margin. This paper became a landmark paper because it described anatomic landmarks in the liver on how to evaluate the margin using pre-treatment and post-treatment images. And subsequent papers showed that if you had a margin measured with that technology, with that landmark image-guided depiction on a CAT scan, and the margin was over 10 millimeters, you could be sure that there will be no recurrence whatsoever. And this was validated by us and many others in several populations throughout the world. And it maintains today as the most critical technical endpoint of ablation. Using this paper then, a lot of industry got very, very, very animated, and they tried to bring these old-fashioned measurements that we gave them on an old-fashioned CAT scan with contrast and put it in a computer to make this initial technology that I told you about 30 years ago and make it high-tech. And how did they make it high-tech? Well, first of all, they created much more potent ablation technologies that they can treat much more effectively than the original radiocautery that I told you. They use microwave or they use other technologies to overcome limitations. Also, we started learning that it's extremely important to have live imaging within the operating room. So not just an ultrasound, but now we have CAT scans and PET scans and 3D software. 3D software in the form of navigation and treatment evaluation is what most of the companies have done to facilitate the way we have evolved over years. The second thing that evolved a lot with industry over the years was the realization that with radiofrequency ablation, we had issues with heat loss. It's called the heat sink phenomenon, where a lot of the heat that we will put on the tumor was going away from the tumor due to flowing blood nearby. So they created higher energy with the use of microwave, which is now the most common ablation technology used in the Western Hemisphere, proven that it can overcome the portal venous flow near the tumor that was a limitation that we had with radiofrequency. And you can see that the microwave ablation extends to the edge of the portal vein, effectually killing tissue all the way to the vessel and not impacted by that. In addition to that, it has much more user-friendly interface, no grounding pads and stuff like that that are beyond your interest, but it's much easier to do, much faster, with very, very similar outcomes. And therefore, from the 90s to today, the platforms we use, the room we use is much more similar to a surgical room full of whatever technology you can imagine than where we were 30 years ago with a simple ultrasound and a needle of electrocautery. This is some of the software assessments that are done with the target tumor, confirmation by the software that the needle has been in place accurately, and then some 3D technology that allows us to overlap the original tumor as depicted in contrast enhanced CT with the treatment zone and being able to tell us whether there is any area of the ablation zone. You can see here a combination of PET CT with contrast enhanced CT. The PET CT was obtained before treatment. The contrast enhanced CT is after treatment. And you can see here clearly that there is a margin of death, a margin of non-enhancement between the AVI tumor and the treatment zone. And if there isn't, then the software will highlight it like here. And you will know that an area of where you thought you treated remains untreated. This here shows it very clearly that there is an untreated zone that maybe you would have missed on the contrast enhanced CT alone. And this area, we know that it will have a very high concordance with local tumor progression or failure. And therefore, in these days, we will go back, and if safe, we will be retreating this area in order to achieve complete ablation with the desired margins. And this is something that we have shown prospectively and retrospectively, and so have others in the United States from MD Anderson or from Europe, Rito Vale, Martin Meyering, and other pioneers of ablation. Using this 3D software technology to assess the treatment zone, the ablation zone, we can increase the sensitivity from 20%, where is the visual inspection alone using CAT scans with experienced interventional radiologists, to 93% for the detection of an area that has been untreated or improperly treated. And then we've shown that if we had this technology in the OR, 70% of cases that fail would actually have been retreated on the spot. Now, another development that was very much related to my belief that we need to reach the surgical standard was the assessment of the treatment zone, of the ablation zone with tissue sampling. And originally, when I was young, back in 30 years ago or so, I noticed that the early ablation devices had charred tissue on them. Similarly, when you put your liver on the barbecue or you're doing your Sunday souvla and you put your fork in the meat, you take it out and there is some charred tissue on it, right? So I said, well, this charred tissue may be very useful. It should be all dead, right? It was on the device that it's supposed to kill tissue. So I started collecting that tissue. It was for free. I didn't have to have pilot money. I had no grants. I had nothing. So I was shaving the tissue from the devices and sending it to pathology. And I would say, post-surgical sample, what is it? And you will be surprised, but 60% was dead tissue. But 40% it was not. And it was roughly 2020 or 2515 that you could actually see intact tumor cell at the end of treatment. Now, in theory, if you read papers of the time, and Naum Goldberg is one of the pioneers who was doing a lot of work on that back then, when I told him this idea, he told me, stop it, you're hallucinating. I said to him, no, that something is wrong. Because why do I see intact tissue? He said, it's going to be dead in 2 weeks. Read my paper. He had a similar paper where he was getting the tumors out in surgery on patients that he had previously ablated, and they had been removed in different times after surgery. And indeed, most of them, if they were 30 days or older, they were all dead. But if you would take them out within a week, you would still see some intact cells. And the theory was that they were undergoing irreversible apoptosis. So in reality, they were dead, but they were not. And then I said, well, if that was true, we shouldn't have any failures. But we have failures. And those failures seems to be the same number with the tissue that I'm getting cells on. So we need to do something more on that. So we kept following these patients, and 5 years later, I wanted to see the difference in survival. Patients that had pathology, coagulation, necrosis, no tumor, 33% survival at 5 years. Those that had tumor on that needle, 8% survival at that year. Something was off here. So I kept working on that, and eventually I was lucky enough, we got 2 NIH grants on that. And the first one was evaluating the ablation zone with a biopsy now, not just collecting the tumor, but actually intentionally and prospectively going back to the treatment zone and sampling the area where the tumor used to be and the surrounding margin. And if we had complete necrosis with a margin over 5 millimeters, our success rates, regardless of the technology we used, were consistently over 93%. No tumor coming back. 93% was treated. But if we didn't, look at the difference. 25% was control. 75% will come back. So this was a dramatic risk. The risk of tumor coming back was 20 times. Hazard ratio of 20.3 if you didn't have a margin or if the biopsy was positive. It took me about 4 years at Memorial to find a PhD specializing in molecular cytology. She was a lovely lady, Katia Todorova-Manova from Bulgaria, and she was our head of molecular cytology. And I told her I need a stain that I can tell if this tumor that I see intact cells on molecular cytology is alive or dead. And she tells me, the only thing I can think of is mitochondrial stains. And I have this sexy mitochondrial stain. It's called mitotrachea red, which is what you're seeing right here, that within 20 minutes, if you give me sample, I can tell you if the mitochondrial is still working or is dead. And you can see here, this is amorphous coagulation necrosis, but you can see the signal here, how it's bright in a constellation of cells indicating viable tumor with expression of mitochondria. So there's no question you could do it. It was the first time we put this in clinical practice, and not on a cell culture, but actually in core tissue biopsies. And when we did that, we found out that actually it was an independent predictor of 12 months local tumor progression if you had that stain viable at the time of ablation. You can see here 78% versus 59%, and it was significant. And that's only with this stain. Forget the margin, forget anything else. If you had this stain, you had a higher chance of coming back. Then we put another issue on the equation, which was that most of the literature on margins in ablation was evaluating the margins 4 to 6 weeks after treatment to avoid post-surgical changes obscuring the real treatment zone. And that was the standard evaluation throughout the literature. So we started looking, can we actually tell with scans that we do on the spot, on the day of the treatment, do a post-ablation scan, does that have the same predictive value, the same sensitivity on telling us who was successfully treated versus the one that is at risk for failure? And sure enough, it showed that the sensitivity of a 5 millimeter margin depicted on the day of ablation was a stronger, more sensitive tool of detecting the ones that actually were at risk of recurrence. Then we had another evolution in this technology for ablation, and that was the real-time use of PET. I'm sure you'll know what PET, positron emission tomography, with the use of FDG, tagged glucose, fluorodeoxyglucose that is tagged, is absorbed by the cells much faster and much more intense than normal tissue. And it's a surrogate image biomarker, especially for colorectal mets and others that are very hard to see sometimes in contrast-enhanced CT, but they are all, or the majority of, over 95%, they are PET-avid. They are hypermetabolic tumor. And therefore, we knew from targeted therapies how important it was to have metabolic imaging for the detection of partial responses to targeted therapies. So then we started using this for biopsies when we wanted to target areas of the tumor that were chemorefractory to guide new targeted therapy. And then slowly we realized, well, if we're doing it for biopsy, why not do it for ablation? Well, the problem with ablation was that if you have a hypermetabolic tumor and you ablate it, the hypermetabolic signal remains the same for like 3-4 hours after the injection. So you couldn't tell whether you treated it or not. So we had to modify the treatment. We spent a couple of years with our physicist and our nuclear medicine specific physicist, and he said, why don't we try this? We're going to give 1/3 of the diagnostic dose prior to ablation. We're going to do a PET-guided ablation using PET and CT, use the 4 millicurie to show the tumor, and once we're done with our ablation, you will give 2/3 of the diagnostic dose to see your treatment zone. By doing this, you allow the 4 millicuries that you gave early to decay enough so the signal from the first injection, it's very much gone and is completely obscured by the new signal of the second injection. That method is called the split dose PET-CT, and you can see it here. Hypermetabolic tumor prior to the ablation, ablate, re-inject, and you can see the lack of signal indicating the ablation zone with the use of the second injection. Now, this technology allows us, with the progression of computers, to do a lot of fusion intraoperatively, like I showed before. And therefore, you can see here a fusion of the pre-ablation PET with the post-ablation contrast-enhanced CT. And that facilitates a post-ablation biopsy of the tumor center where the tumor used to be, but also the margin. and it made our methodology much more accurate, and it allowed us to secure a large NIH R01 grant where we put all this technology together, 3D software navigation and treatment assessment, split those PET-CT and immediate tissue assessments with cytology and molecular cytology. So everything I described to you all together in a grant, and we evaluated in 107 colorectal liver mets to show that 15%, 14.4% had evidence of incomplete treatment that we wouldn't know otherwise, and therefore they were retreated on the spot to achieve results similar to those that were properly treated. Of note, a lot of people say, well, you can only do that in that institution that is the cutting edge institutions. Well, the truth is you can do them anywhere as long as you have dedicated PET-CT, and the PET-CT gives you the time to do an anesthesia-based procedure. But of note here is that most of these tumors had a finding, and only one had all the risk factors together. So this tells you that you can't just say, I'm going to do margin assessment, or I'm just going to do biopsy, or I'm just going to see, whether the PET signal at the end went away or not. You really need all three to maximize your effect. Then another issue that is very important and is very well known in colorectal mets, it's really the impact of some mutations, and KRAS mutation is a very common mutation that if you have it, you should know that it's refractory to treatment, but it's also refractory to ablation. And for those tumors, you really need a 10 millimeter margin to have successful ablation. And if you cannot at least treat with a 5 millimeter margin, then you might as well not treat them at all, because they are really going to recur. And the high risk for those if you have suboptimal margins and positive biopsies is 17 times that if you don't. Now, a lot of others have compared ablation to surgery. Here is a prospective multi-center match cohort study. It's not a randomized control trial. It's as close to that as I can be, where it shows that stereotactic microwave ablation had very similar 3 and 5 year survival with resection, and of course, a better complication profile than resection. For those of you that are interested in this field and colorectal liver mets, the most recent publication in the area comes from the Netherlands, from this multi-center randomized controlled trial under the PI of Martin Meyering, which is a good friend and a very good interventional oncologist. He randomized small colorectal liver metastases to resection versus ablation, either the radiofrequency or microwave. He demonstrated non-inferiority to all oncologic outcomes, including overall survival, progression-free survival, per patient disease control, and of note, what is probably non-expected, a better target tumor control by ablation rather than resection, which was actually a very nice surprise. Now, it is based on this data that the 2025 National Comprehensive Cancer Network recommendations, which is the United States recommendations based on which insurances will approve or not approve a treatment, recommend thermal ablation in selected surgical candidates. So not just non-surgical candidates anymore, but actually people who could go to surgery could have instead ablation, as long as the tumor is small, that can be ablated with margins. And I'm not sure how your radiation oncology community is, but there is sometimes a debate whether radiation should be done instead. And the truth is that the evidence for radiation is not equivalent to either ablation or resection, and thus only candidates that are not amenable to either resection or ablation should be going to radiation therapy. Now, the ACCLAIM trial is a trial that is an ongoing. I just happen to be the PI with the funding from the Society of Interventional Oncology. The reason we did the ACCLAIM, why do we need the ACCLAIM after all these trials that I sent you? Well, the reason for the ACCLAIM is to try and standardize the way we do ablation between very different settings from New York City to Athens, Greece. So this was done in 10 centers, 5 in the United States, 5 in Europe. And the common denominator is that we all treat with a final endpoint of a 3D stereotactic depiction of the ablation zone completely covering the target tumor with a margin over 5 millimeters. Other than that, this trial is device naive. You can use any ablation device you want, and you can use any 3D software platform you want, as long as it's FDA approved or CE marked. So as long as it's approved in the US or in Europe, it's allowed to be on trial. Now, if we do have time, we can talk a little bit more about patients that are not candidates for local cure, but unfortunately, they have multifocal chemorefractory disease, where the argument for local therapy is much less than what I argued before. And many people will say, well, why do you even think of treating people with multifocal metastases? Look at this patient. The liver has almost completely been replaced by hypermetabolic metastases. Are you going to give them a local therapy? Well, so let's stand back and say that the rationale for thinking about this is, first of all, because we can. And the reason we can in the liver is the dual blood supply to the liver. And if you are in medical school and you don't know that, that's a primary knowledge that you have to learn very well. So the liver gets supply from the portal vein by 80% that primarily supports the parenchyma. And it gets 15 to 20% supply from the hepatic artery that mostly supplies tumors that are hypervascular. So even tumors like this, these are colorectal mets, that in the portal venous phase CT, look at how dark they are. When you do a CT arteriogram, they light up like a light bulb because they get supply from the artery. So this particular anatomy in the liver is what allows us to develop what is known intraarterial therapies in the treatment of metastases. Here is an example of how we treat hypermetabolic or hypovascular tumors in the liver with what is now known as radioembolization or selective internal radiation therapy, which are radioactive spheres, and that's why we're all not touching this thing because it's full of radiation, delivered through the femoral artery in this case, but it could be the radial artery, going all the way to the liver using combination machines that technology now provides, where combined angiographers with either cone beam CT, rotational computer tomography, or real tomography, combining CAT scan with an angiogram. And if you don't have one in the general hospital, I know my friend Dr. Poulos is here, you should get him one, because really it changes the way you can practice very, very complex interventions. So we're talking about patients now that they are non-surgical candidates, non-ablatable, they have more than 3 metastases, or they have larger metastases. We expect them to live over 3 months at least, and they have a relatively good performance status. Using radioembolization, we're able to give doses over 100 gray and even higher, rather than the radiation-induced liver toxicity, which is at 30 gray. The reason we're able to do that is because we only target the artery, and therefore the portal vein allows the liver to recover. I'm going to show you some data here so you have an idea of what's happening in this space. This was a very large, multi-center, international trial. It enrolled over 1,100 patients that received oxaliplatin-based chemotherapy with Avastin or bevacizumab plus minus, and then the treatment arm received the same chemotherapy with radioembolization with resin microsphere. There are two devices, resin or glass. This trial was with resin. They showed no improvement in overall survival and no improvement in progression-free survival, but an 8 months improvement in liver disease control. Also, a 5-month improvement in survival on those patients that were chemorefractory, patients that had right-sided disease. Similarly here, using glass microsphere, they demonstrated much better disease control in the liver and a protection against progression in the liver or anywhere in the body. Several trials were done with this technology in the chemorefractory salvage setting, all of them showing survivals anywhere between 9 to 15 months. Factors impacting outcomes was mostly the presence of extrahepatic disease and the ability to do that may be shown very well in this trial that we did at Memorial, where we had no extrahepatic disease and we treated patients that they were previously treated with hepatic arterial chemotherapy, and we had one of the longest survival in this very advanced stage of disease. These are patients over 4.5 years from original diagnosis, living 15 months. And the reason for that is that this population had no extrahepatic disease whatsoever. If you look a little bit of what's happening in this space, and this is a population from the same institution, but this population has 77% extrahepatic disease, median survival 11.4 months, but I wanted to pay a little bit of attention to the risk factors. We create this nomogram with the help of our statistician, Mithat Gonen, which is actually from Turkey, and he's working with us for over 30 years, and he's a great statistician. He's a specialist in colorectal cancer over the years. He put points for each one of these factors: the tumor size, the presence of extrahepatic disease, CEA, albumin, tumor differentiation. And the reason I wanted to pay attention is that all these patients are considered to be terrible. They're all going to die very, very fast. But look what's happening. If you have a lot of risk factors over 80, then 1 year survival is 10%. But if you have, again, they are all very advanced stage of disease. But if they don't have so many factors, risk factors under 25 points, 1 year survival, 90%. So really the biology of disease here tells you that it determines the outcomes. And as we're closing towards the end of this talk, I know you guys are probably tired by now. I'm talking good 40, 45 minutes. One other factor that seems to be very important is the ability to irradiate the tumor with appropriate radiation. So this paper showed that in the same population, if you can give to the tumor over 100 gray, survival is much better than if you cannot. We did the same here, and we showed that indeed this is true. And if you're using resin and you can give over 60 gray, survival is over double that if you cannot. And the same with glass. There, the radiation dose is higher. If you can give over 120 gray, again, survival 26.4 months versus 10 months. So is it justified to do these treatments in the chemorefractory advanced setting? Just for the understanding here for everybody, if you don't treat this population, they're going to live 4 to 6 months. If you give them the approved systemic drug, which is Lonsurf or TAS-102 or regorafenib, their survival is improved by 6 weeks. So they will live 7 months. So all data from what I showed you range for survival from 9 to 15 months. So it's clearly a survival benefit, although I don't have a randomized trial on this. So where are we going with all these treatments? So one avenue is that we're using all of these technologies to replace or to have the same outcome as surgery. One was ablation, but also the yttrium-93 embolization that I just described to you has now evolved to be able to deliver very, very high doses. And by doing that for small tumors that cannot be resected or ablated, as you can see here, if we can give over 400 gray to the tumor, with a margin over 350, we have no recurrence. But with current technologies, we achieve that in 15%, or with all comers. So we have to find ways to improve dosimetry. Similarly to here, if we can cover stereotactically 95% of the tumor with a dose over 300 gray, we have no recurrence whatsoever. But so far, we only achieved that at 11%. Now, dosimetry is improvement. It's there, but there's a fine balance. How do you radiate the tumor, minimizing the exposure to the rest of the non-involved liver? So we have an ongoing grant that is supported from the Society of Interventional Radiology, where we actually use all the tools that I described so far, and we do a post-treatment immediate PET-guided biopsy of the treated tumor, and we correlate the radiation that was delivered to the tumor with actually the pathologic evidence of complete tumor necrosis to see the real threshold. What is really the tumor killing dose that we need to deliver? We also evaluate the immune response from this treatment. We know that rarely we can treat one area and then a non-treated area goes away because of immunomodulation, because cancer cells were exposed to the general system, and some T cell populations have been developed to kill those cells in remote areas. And we do know that ablation can be possibly used as a vaccine against cancer. We're not there yet. The same goes for radiation. So this is really an evolving field on how to use these local therapies to elucidate a general response, not unlike what a vaccine will do to inflammation. Finally, there is a lot of development from technology where bloodless, needless technology has evolved. This is a new technology called histotripsy, where they use navigation software and very advanced computers to focus ultrasound in the area of a tumor where acoustic energy destroys the tumor instead of having hit with a needle or resection with a knife. And then a lot of us are thinking, where are we going with artificial intelligence and robotics? Are we still going to be around as interventional radiologists or surgeons or physicians? And the truth is that if we want to think where we came from to today and where we're going to go maybe in the next 30 years, I think at least in cancer, all treatments will be individualized and tailored. We will have to collaborate between different specialties to achieve really treatment for our patients. Medical oncology will exist. I don't know what chemotherapies and targeted therapies will be, but I think they're going to be much more gene related. Immunotherapies are evolving extremely fast, so I think that's an area of very fast development. And IR and IO and surgery will have a lot of things to do in synergy with immuno-oncology. Of course, we're going to have gene oncology as we move forward, and maybe some of these diseases will be attacked early on so they don't get a chance to metastasize. And what about any surgery or interventional or radiation, local therapy? I think this will be one specialty altogether, and it's all going to use image guidance, navigation, robotics, anesthesia, and it's going to be a common specialty 30 years from now that probably will have no knives, no needles, and bloodless local therapies. With this, I want to thank you for your attention and also thank all my collaborators in my research lab through the years. Thank you very much again.